Thank you, ma'am. At the outset, thank the organizers for the opportunity. I'll be continuing where Minit has left off in our quest for prolonging the survival. Um, our conventional wisdom has been consolidative therapy increases survival. NRG-LU002 was a different outcome, has a different outcome. So this was a randomized phase 2-3 trial of maintenance systemic therapy versus local consolidative therapy plus maintenance systemic therapy for limited metastatic non-small cell lung cancer. They have used the word limited metastatic. The definition for oligometastatic is further adding to the confusion. Background local therapy, especially radiation, has been used for palliation with better systemic therapy, targeted therapies, immunotherapy, and improved imaging, as well as development of SBRT. Interest has increased in using ablative therapy, that is radiation in this scenario, or surgical approaches as local consolidative therapy to improve oligometastatic NSCLC survival. There is a theoretical advantage to local therapies, time to for systemic disease to declare itself, ability to evaluate response of the disease to specific systemic therapies, fewer sites that can be potentially treated, and timing that will limit the development of acquired resistance. We have a large data of prior randomized studies that have utilized mainly chemotherapies and that has shown that local consolidative therapy increases the PFS. But none of these trials have incorporated immunotherapy. There have been single arm trials of IO plus salvage local therapies that have shown some numerical benefits in TFS. So what are the methods in NRG? Multicentric trial. This is the method in the schema. Important is the timing. They included patients with metastatic NSCLC having completed at least 4 cycles or courses of first-line induction systemic therapy. They were open to all inductions. They have not certified, at least the abstract does not certify what are the induction therapies used. Restaging studies that reveal no evidence of progression and limited metastatic disease, classified defined as 0 to 3 discrete extracranial sites. They have not included brain. All of which must be amenable to SBRT, radiation with or without surgery. So SBRT is one of the prime modalities of consolidative therapies that they have included. A minimum of 1 disease site, metastatic or primary, needs to be present after first induction therapy and treatable with local consolidative therapy. They have stratified as squamous versus non-squamous, and the continuation maintenance, that is the systemic therapy, as immunotherapy, cytotoxic chemotherapy, or other induction regimens of combination. Arm 1 was only systemic maintenance therapy. Arm 2 had SBRT / radiation or surgery. The irradiation was followed by maintenance of systemic therapy. Now the catch here was that all Arm 2 patients, even if treated with surgery, must have one side of disease treated with radiation. Maybe biased towards the radiation oncologist who were maximum in the investigator group. If a metastatic site is best treated with hypofractionated radiation, this will be permitted if SBRT or surgery was not indicated. It enrolled 218 patients from 68 sites. The primary and the secondary outcomes. The primary outcome was PFS, defined as no evidence of progression or limited metastatic sites after first-line systemic therapy, and OS. OS was no evidence of progression, limited metastatic disease after first-line systemic therapy. Secondary objectives, quality of life, and ctDNA outcomes. This is the primary hypothesis. The primary hypothesis was that the local consolidative therapy improves the PFS in the OS. For the PFS, they considered an improvement in 6-month and 12-month rate of PFS at 60 to 75% and 12-month from 39 to 57% for a hazard ratio of 0.6. For the OS, they looked at a 12-month increase in the OS from 68 to 77 and a 24-month increase in the OS from 47 to 61 with the hazards of 0.68. This was the RT criteria included. This was the systemic therapies, maintenance therapies. They have to start within 2 weeks of registration. They included GEM, Pembro, Nivo-EP, Atizo. These are the results. Well matched both arms, male, female, the gender and the ethnicity. Histology was matched. Now this trial included nearly 90% of patients in both arms who had received maintenance immunotherapy. Number of lesions 1 to 2. Most of the patients were PS 0 or 1. Now these were the results of the patients post induction therapy, that is after 4 courses of treatment of induction therapy. Most of the patients were in stable disease. There were very few complete responses. There were few partial responses. And the plan for the local consolidative therapy, they have not included the number of patients undergoing surgery in the abstract clearly, but majority of the local consolidative therapy was for the primary tumor, followed by mediastinal nodes. Then there was bone, sites in the lung, liver, spine. This trial had included cranial sites. So this was a PFS. Surprising outcomes. 1 year PFS rate in the systemic therapy arm was 48%, while in the local consolidative therapy plus systemic arm was 51. Hazards of 0.6. The 2 year PFS was not very optimistic, 35 versus 40. This is the OS. The OS was actually detrimental at 2 years, 58 in the systemic therapy arm versus 54 in the local consolidative therapy arm. When you start losing, you look at straws, you want to look at beautiful outcomes, you want to look at different data, look at the data differently. So this is cumulative incidence of time to in-field failure. They wanted to see whether there's another way that we can present the data. So this was death without in-field failure as a competing event. They wanted to look at patients whether immunotherapy or whether the consolidative therapy contributed to maybe out of field failure. So even in this, there was no significant advantage of using consolidative therapy. The second novel outcome criteria that they used was time to new lesion development. That is death without new lesion development as a competing event. Even in this, the hazards are crossing unity. Results toxicity in the systemic maintenance arm, 11 patients, that is 15% at grade 4 and 4 patients at grade 5 adverse events. Well, in the local consolidative therapy arms, it was 15% and 8%. And adverse events related to treatment. For the adverse events related to treatment, there is definite, probable, and possible. Because patients with the overall, that is the LCT arm, they had higher toxicities attributable to the treatment. Limitations. It is agnostic to systemic therapy. No single regimen was followed. Definition of oligometastasis is ambiguous. It was determined by one cross-sectional imaging. No biomarker enrichment was done at the 3-month cutoff for starting the treatment. No clear understanding of metastatic disease trajectories. Previous studies had not randomized patients in IO era. So the take-home point here is, if the survival with IO or survival with better targeted therapies is much more, does addition of consolidative therapy contribute much? So the NRG-LU002 definitely says that addition of consolidative therapy in patients who are now taking immunotherapy might not be the best way forward. Thank you.